Welcome everyone to Population, Family, and Reproductive Health's noon seminar. I'm Cynthia Minkovitz, chair of the department, and today it gives me great pleasure to kick off the start of a series that will take place throughout the academic year, focused on the intersections between life course and cardiovascular health, particularly among women. This series is co-sponsored by the Division of Cardiology in the School of Medicine here at Johns Hopkins and the department. Within our department, this focus builds on the work of multiple teams, including that in the Center on Early Life Origins, focused on early precursors of adult disease, including cardiovascular disease, as well as the emerging work of the Early Childhood Services team, using home visiting as a service delivery strategy to promote cardiovascular health for both mothers and their young children. In co-developing this series, I've had the really great fortune to partner with Dr. Erin Michos in the Division of Cardiology, so it seems only fitting that she'll lead us off today. Before introducing Dr. Michos, I'm excited to share two additional speakers that are already set for the seminar. One is Dr. Sadia Khan, who will be joining us on December 8th, and she's on faculty at Northwestern University. And then another known to many of you, Dr. Wendy Bennett, who's on faculty here in the School of Medicine and also in our department. And Wendy will be sharing some of her clinical trial results, focusing on limiting gestational weight gain and preventing obesity, and thinking about those challenges between RCTs that are great and actual clinical practice. So we're excited about those. Turning our attention to today's seminar, as I mentioned, I have the honor of introducing Dr. Michos. So she's an associate professor in the Department of Medicine, the Division of Cardiology here in the School of Medicine, and she holds a joint appointment in epidemiology. Her research has focused on women's cardiovascular health with a focus on preventive cardiology. She's a highly experienced and well-known clinical investigator with extensive experience in cardiovascular disease risk reduction, including the use of coronary artery calcium scores, cardiac troponin, inflammatory, and other novel biomarkers. She also has expertise in cardio-obstetrics, and for those of you not familiar with that area, that's the focus on improving maternal cardiovascular health through pregnancy, delivery, and well beyond. And importantly, she's contributed greatly to our ongoing thinking about how do we achieve adequate representation of women in cardiovascular clinical trials. She serves as co-editor-in-chief of the American Journal of Preventive Cardiology, which is the official journal of the American Society of Preventive Cardiology, and she's the associate editor for Circulation. She's also a highly recognized mentor, and she serves as a training director for 3 research networks, including those that focus on women's health, cardiometabolic health, and health technology. Today, I'm excited that she's going to share some of her work on female-specific factors that impact women's cardiovascular risk across the lifespan. So welcome, Erin.
Thank you so much for having me here in your seminar. Let me get my slides up here. Oops, sorry, it's already advancing. Let me get my pen. Okay, so let me know if you can't see my slides. So as you heard, I'm going to talk about sex-specific factors that enhance a woman's cardiovascular risk across the lifespan. So first, this is probably well known to this audience, but usually when I'm talking to cardiologists, I kind of emphasize that sex and gender are not interchangeable terms. They actually mean something different. You know, when I refer to sex differences, I'm talking about differences that are biological or related to sex chromosomes, sex hormones, gene expression, anatomy, where gender is a social cultural term related to enacted roles and behaviors. It's about identity. It's not binary. It's on a spectrum. And health is determined both by biology and the expression of gender. So both sex and gender contribute to observed differences in women or females' cardiovascular health. So first, some epidemiology. You probably have all seen statistics like this from the American Heart Association. This is cardiovascular mortality. So in the 70s and 80s, cardiovascular disease mortality was going down in men. Men were getting statins. Their cardiovascular risk was being paid attention to. Where women were not getting statins, they were given hormone therapy, their cardiovascular risk was being ignored, and actually cardiovascular mortality was on the rise until finally reached people's, a great attention at the end of the 90s, early 2000, where it was the launch of the first women-specific cardiovascular prevention guidelines and the Go Red for Women campaign by the AHA and other initiatives. And then cardiovascular disease mortality did have a nice decline for women as well as continued decline in men. And this is why I like being a preventive cardiologist, because it's largely has been a success story with this tremendous decline in cardiovascular mortality. But still, for many, many years, more women in terms of absolute numbers were dying of cardiovascular disease compared to men, despite this kind of pervasive myth that vascular disease was this disease of men. Now, in the year 2013, women dipped a little bit below men, and I'm happy to take second place for cardiovascular mortality. But I think all of us need to be really concerned of what's happening here at the right end of the curve. In both women and in men, we are no longer making the same progress in reducing cardiovascular mortality. There's been a stagnation and even an uptick, likely driven by the epidemic of obesity and cardiometabolic diseases like diabetes. And actually, when you look at rates, the fastest growing rate of heart disease is in middle-aged women, age 45 to 64, which increased 7% since 2017. And I fall in this age range. This is a time in life when many women are focused on both their children and their aging parents and their careers and everything else that's going on, and often that they don't often get to have a chance to prioritize their own health. Now, this is one of my studies published earlier this year looking at mortality in younger women under the age of 65. And in younger age ranges, cancer is the leading cause of death of women. And what we showed in this national data set from the CDC from 1999 to 2019 is that cancer mortality was continued to decline in younger women under the age of 65. But unfortunately, since 2010, there's no longer a decline in heart disease mortality. It's actually been an uptick with annual percent change of 0.5% per year. But if these trends are not overturned, now there's a narrowing of the gap between cardiovascular and cancer mortality. And if these trends are not overturned, cardiovascular mortality may overtake cancer as the leading cause of death in younger women too. And this is one of my studies published last year in JAHA, where we looked at age of diagnosis in cardiovascular disease and its risk factors. And for both men and women, but more so for women, cardiovascular disease is being diagnosed younger and younger. For example, in stroke, on average, has been diagnosed 1.2 years younger than men. Risk factors such as blood pressure and high blood pressure and high cholesterol has also been diagnosed younger. Now, this could mean that maybe we're doing better about screening for risk factors in younger adults, but I think what it means compared to, in line with other data is actually the cardiovascular health is getting worse in younger adults, and that's why it's being diagnosed in younger and younger ages. Now, unfortunately, and I was really disheartened by this study, is that awareness that cardiovascular disease is the leading cause of death is actually going down. And, we wear our red dresses every February, and, I'm out, speaking to, I guess, the choir only about cardiovascular disease mortality. I thought we were getting the message out there. But the American Heart Association has sent out surveys to women over the years. And in 2009, 65% of women respondents reported that heart disease was the leading cause of death. And that actually declined only 44% in 2019. So we're losing awareness. More women are likely to cite breast cancer as their leading cause of death. And this lack of awareness was greatest among Hispanic and Black women, and also among younger women, who arguably we can do the most for primordial and primary prevention, because prevention works best when you start young. Now, I'm sure this group's familiar with the traditional risk factors for cardiovascular disease, but even among traditional risk factors, there can be disparities by sex. For example, diabetes confers a greater relative risk of cardiovascular disease in women than in men. So these are various cardiovascular outcomes. I'm just going to focus here on myocardial infarction, where diabetes confers a 4-fold increased risk in women in the gray bars versus 2-fold increased risk in men in the black bars. Likely this is due to when women are diagnosed with diabetes, they tend to be diagnosed at a higher body mass index and with more underlying cardiometabolic risk factors at the time of diagnosis. So they have a more severe onset risk of CVD at the time of diagnosis. Additionally, smoking is a greater relative risk in women than in men, particularly in younger women. And of course, smoking is bad for everybody, but it's a greater risk in women. Additionally, there are some sex differences in blood pressure. So hypertension at older ages is more common in women than in men. And so there had been some thought that somehow hypertension, accelerates after menopause. But really, that's not what the data suggests. The data suggests that women are on a different blood pressure trajectory their whole life, that women on average start with a lower blood pressure than men. But at middle age, after the age of 60, they're on a steeper trajectory that their blood pressure overtakes men. They have a higher blood pressure than men at older ages. So that you see this whole, if you look at the elevation over lifetime, that women are on a steeper trajectory and have a greater elevation from baseline. And so this sets the stage for cardiovascular disease, not only presenting later in life in women, but also presenting a bit differently. In addition, there are unique risk factors that women experience throughout their lifespan that men do not experience, related to pregnancy and hormones and menopause. And I'm going to review just a few of these today. There's actually a lot of them I don't have time to cover. In younger women, we think about age of menarche, polycystic ovarian syndrome, oral contraceptives when combined with smoking, infertility, as well as infertility treatment may be an independent risk factor, premature ovarian insufficiency. So early menarche, the onset of menses. So when you look at cohorts of middle-aged women, such as this Norfolk, UK study, and ask them about when did they have their age of menarche, women who had onset of menses at younger ages, 8 to 11, were much more likely to be in worse cardiovascular health later in life with a higher waist circumference and body mass index and more hypertension. But even in adjusted analysis, there seems to be a U-shaped relationship with menarche and incident cardiovascular disease risk, where both early menarche before the age of 10 being associated risk, as well as late menarche after the age of 17. So the early menarche, thought that this is related to increased weight, that these girls had greater weight than in prior decades, and that it's concerned that maybe adipokine dysregulation in teenage years may set the stage for later metabolic imprinting for later life cardiometabolic dysfunction. And the late onset menarche may be due to hormonal imbalances, and estrogen deficiency, another thing that may set these women up for vascular risk too. The mechanisms are not completely elucidated. Another important risk factor in younger women is polycystic ovarian syndrome. And it is a heterogeneous condition. There's different groups with different definitions. It does seem that the really riskier form is the form that's combined with hyperandrogenism. But polycystic ovarian syndrome is predominantly a disorder of insulin resistance, and there are interesting genetic and other reasons for this, which manifests itself as, in dyslipidemia, elevated triglycerides, low HDL, elevated blood pressure. Most of these women, but not all, also have elevated weight, body mass index, and this increases the risk for subclinical and clinical cardiovascular disease, such that women with PCS are more likely to have carotid plaque prevalence compared to weight MASH controls, and perhaps a twofold increased risk of coronary artery calcium, a marker of atherosclerosis that I'll talk about. And there has been some, disagreeing data, but many studies have suggested that polycystic ovarian syndrome is associated independently with an increased risk of cardiovascular disease, about twofold. And this risk seems to be greatest for younger women under the age of 50. It seems to be less of a risk once a woman's already above 50 years of age. Now, I thought this was interesting. Some studies have looked at irregular menses, which is a simple question that you can ask as a marker of PCOS, kind of a surrogate of PCOS. But even asking about irregular menses, this is also associated with cardiovascular risk. I forgot what they defined it in this study. Many studies have said less than 6 menstrual periods per year. But in this Nurses' Health study, women with very irregular menses was a 53% increased risk of an incident cardiovascular event throughout one's life. And migraine headaches have also been associated with increased cardiovascular risk, that we think that the risk is around 73% in this meta-analysis. And the mechanisms have been postulated related to hormonal imbalances, or that women with migraines may have more traditional risk factors or inflammation, or maybe it's what's the chicken versus egg? Maybe they have the migraines and are taking NSAIDs and that increases their risk, or maybe being laid up in bed with a bad headache increases your risk, or there's been a lot of interest in looking at whether this is related to patent foramen ovale. although closing PFOs doesn't seem to help the migraines or the cardiovascular risk. A lot of the interest has been focused around pregnancy, adverse pregnancy outcomes. And I should mention, I hope throughout the whole theme is that I'm trying to obviously set the stage of why it's really important to ask patients about a comprehensive reproductive history as part of our cardiovascular risk assessment. That although we can't go back and change when we had our onset of menses, asking women about these questions may identify women that might be at elevated risk that we may not otherwise be aware of if we didn't ask the question. And this is the same thing with asking women about their pregnancy history. Women remember their pregnancies very well. We just need to ask them about this history. Both Parity itself, as well as adverse pregnancy outcomes, such as preeclampsia, gestational diabetes, preterm delivery, small for gestational age, have all been shown to be associated with increased cardiovascular risk. So first of all, there's been a lot of studies and some of my own work related just with Parity, the number of live births. And one of our studies led by Shea Ogumorto looked at and using data from the MESA study, the multi-ethnic study of atherosclerosis. Hopkins is one of the 6 field centers. And so at MESA, women are now middle to older age. But asking women about their prior Parity history, women who had a history of 5 or more live births were much more likely to be in inadequate or poor cardiovascular health using the HA Life Simple 7 score compared to women who were less porous. And then there has been data suggesting a J-shaped relationship with women who have a ground multiparity being associated with increased risk of cardiovascular disease, even after adjusting for risk factors. And again, the reasons for this is not known. It may be, women tend to gain weight with each pregnancy, and it may be, adipokines was one of the focus of our work for our SFRN center. It may be adipokines play a role both in normal and abnormal pregnancy, and maybe there's adipokine dysregulation that also sets these women up for later risks. We did in MESA, led by a medical student, Carla Rodriguez, who's a Hopkins medical student here, led this study that's now accepted in press. She presented the HA last year, looking at adipokine levels at older age with Parity history. And we did find that grand multiparous women here in the yellow, more than 5 live births, were more likely to have higher leptin levels, higher resistin levels, lower adenopeptin levels. Now, many of this was attenuated after you accounted for body mass index and risk factors, but higher resistin levels remained associated with Parity even after full adjustment. And then we've also looked at Parity with sex hormones. I'll show you some more data that I've done a lot with sex hormones evaluation and cardiovascular risk, but we looked at this with Parity. This was led by Dr. Bridget Kazi, who is an internal medicine resident at Hopkins, who plans to pursue cardiology. And she found that grand multiparous women, more than 5 live births, even in multivariate adjusted analysis, when we adjust for like everything we can, including lipids and blood pressure and diabetes, that grand multiparous women were 19% more likely to have a higher androgen levels, particularly this testosterone and estrogen ratio, that they're more likely, these are all postmenopausal women at this point, but having a prior high Parity was associated with this higher androgen levels, more testosterone related to estradiol. We've also looked at Parity and subclinical disease. I don't have a slide of it, but we have looked at Parity and carotid plaque and showed the same thing, that grand multiparity, after adjusting for risk factors, was associated with increased risk of prevalent carotid plaque. And this is coronary artery calcium that we presented at AHA last year. And we see, that across groups, grand multiparity was associated with both prevalent coronary calcium, a marker of atherosclerosis, as well as greater extent. And although that coronary calcium itself predicts risk, as I'll show you in other slides, that a high Parity within each CAC score also was associated with even greater risk. So gestational diabetes, this audience is very familiar with the risks conferred to this. It's 1 in 10 pregnancies, but up to 70% of these women will develop type 2 diabetes within 5 years, which is why it's so important that we have programs like Dr. Bennett's been exploring to try to improve the cardiometabolic health of these women after pregnancy, particularly focusing on lifestyle. Because even after adjusting for other risk factors, GDM has been associated with a 25% increased risk of subsequent cardiovascular disease in the mother. And this is after adjusting even for type 2 diabetes later. And one of our star cardiology fellows who did a cardio obstetrics fellowship with us last year, she's our chief fellow this year, Dr. Anna Michos, led one of these studies in collaboration with Janet Katoff and from McGee Women's. They had an interesting data set with women who had adverse pregnancy outcomes like preeclampsia and gestational diabetes, and then 10 years later had underwent an echo and other subclinical testing. So we were focusing, her group's already published the preeclampsia data for echo, and we looked at gestational diabetes and later life subclinical disease 10 years later after the index pregnancy. And what we showed is that women who had gestational diabetes compared to controls were more likely to have thicker walls, more concentric remodeling. They were more likely to have diastolic dysfunction measured by a low E prime, and were more likely to have poor brachial reactivity, a worse reactive hyperemia index, and they also had worse microvascular dysfunction as measured by this glycocheck. Now, some of this was attenuated by later adjustment for diabetes, because a lot of this is like, well, how much is this risk from GDM and how much is because they developed type 2 diabetes? But after we account for current diabetes, we still found that gestational diabetes was associated with worse diastolic dysfunction and worse brachial reactivity 10 years after their GDM pregnancy. Now, preeclampsia particularly is a red flag of risk. It's made into our guidelines. It affects 5 to 8% of pregnancies. So I'll show you it's associated with acute cardiovascular complications and mortality at delivery, but it's also associated with later term maternal risk, sometimes even more than 10 years after the index pregnancy, with a 4-fold increased risk of heart failure, a 2-fold increased risk of subsequent cardiovascular disease, particularly risky if it resulted in preterm delivery. And 2 out of 3 women who experience preeclampsia will die of cardiovascular disease. So this is why it's so important that we plug these women in. And there's, with a preeclampsia, post delivery follow-up to make sure that they're plugged in and get their risk factors paid attention to. And this was one of the studies led by our fellow, Dr. Michos, looking at acute cardiovascular complications. And again, as many studies have shown, in this US sample, we also confirmed that Black women were 45% more likely to have preeclampsia. But across all race ethnicities in this national US sample, preeclampsia was associated with increased risk of cardiovascular events like peripartum cardiomyopathy and heart failure and edema. And so this is why it's so important to try to prevent preeclampsia if we can and manage blood pressure. And unfortunately, there is tremendous racial disparities, which are likely driven by social determinants of health and structural racism. But Black women are unfortunately 3 to 4 times more likely to die of a pregnancy-related death compared to white women. And the leading cause of pregnancy-related deaths is cardiovascular disease. And so there's a lot of interest in people working very hard about how we can reverse this and improve maternal health for Black mothers, because the United States is the worst for maternal mortality has been on the rise compared to other developed countries. So what is the chicken versus the egg? Like, why are these adverse pregnancy outcomes associated with later life cardiovascular risk? Well, it may be that these women weren't all that healthy at the time that they became pregnant, which is why there's a lot of focus about upstream improving cardiovascular health in youth and young adulthood, prior to pregnancy, because it's maybe that these women already had elevated body mass index. Maybe they had subclinical cardiometabolic factors like glucose intolerance or hypertension, dyslipidemia. Women were having pregnancies at older ages. And so they had these subclinical risk factors, and then they became pregnant as nature's free stress test. And then these became clinically manifest in terms of the clinical outcomes of preeclampsia and the other APOs. But it's also thought that these adverse pregnancy outcomes may increase cardiovascular risk in a causal fashion, that the thrombotic and inflammatory milieu of preeclampsia and the angiotensin and some of these biomarkers that we're measuring, this may directly further worsening endothelial dysfunction in a causal fashion that set these women up for greater vascular risk. And this is why it's so important for me, as I'm telling my cardiology colleagues, that we might be seeing these women in our clinic, and they might be outside of their childbearing years, or maybe they had a hysterectomy and are not at risk for pregnancy. We still have to ask about their pregnancy history because we might identify these women at higher vascular risk that we may not be capturing if we just focus on the traditional risk factors alone. And so there's been a lot of interest about improving cardiovascular health upstream. As I mentioned, one of my collaborators, Dr. Khan at Northwestern, is going to be speaking to you all later this year. She's done a lot of work at Northwestern about improving maternal health. And we wrote this editorial in JAHA about trying to focus on the upstream contributors, and it's particularly social determinants of health, and avoiding these adverse pregnancy outcomes. Because really, we need to improve the health of mothers, because maternal health also influences in cardiovascular health. This is one of the studies from that Northwestern group that Dr. Khan's part of. This was led by Dr. Parikh. But if you looked at mothers' cardiovascular health score, mothers that had a worse cardiovascular health was associated with a worse cardiovascular health in their offspring. And so supporting young women, especially before, during, and after pregnancy, is really critical to optimize both mothers' outcomes and also their offspring. So what about older women? Well, there's issues related to early menopause. There's maybe issues, which is my research is focused on, about sex hormones after menopause and menopause hormone therapy and the timing around that. So lots of studies have shown that premature menopause is associated with increased risk of incident cardiovascular disease. So the average age of menopause is around 52, and it's sort of this linear fashion, but particularly before the age of 45 or before the age of 40, there is excess cardiovascular risk in the range of about 30%, even after accounting for traditional risk factors. And that's why that's one of the risk enhancing factors I'll show you. So some of my work has been focused on sex hormone levels after menopause. So the postmenopausal hormone, at time of menopause, with the final menstrual period, there's this acute drop in estradiol levels as the ovary stops making estradiol. But the postmenopausal ovary can continue to make testosterone even up to 10 years after menopause. And so ovary produced testosterone actually contributes significantly to the circulating pool of testosterone, where it's estradiol levels after menopause is often from adipose conversion. So we looked at sort of the ratio of testosterone and estradiol in older women after menopause in MESA, and showed that women who have higher testosterone levels, even after we adjusted for all the traditional risk factors, blood pressure, diabetes, all the cholesterol, all the risk factors, that was independently associated with having an incident cardiovascular event in MESA, both a coronary cardiovascular event or a heart failure event. And I didn't have time to get into all of this, but my lab group has done a whole bunch of things in MESA looking at different markers. And we generally keep showing consistent finding that higher testosterone, particularly it's the free testosterone level that we find is the strongest marker. But that's associated with an adverse concentric remodeling over 10 years on cardiac MRI. Women with higher testosterone levels have more aortic stiffness, reduced brachial activity, more atherosclerosis progression, higher BNP levels. I showed you the event data, and we also showed more likelihood of cognitive decline in the ERIC study. So the problem is, whenever I publish all these studies, we always get the same comment from the reviewer. Well, that's, interesting. What do you do about it? Because of these large clinical trials that had not shown a benefit for hormone therapy after menopause in reducing cardiovascular events, with the caveat that these were conducted in generally older women. So the really pivotal trial was the Women's Health Initiative that was published in 2002, but the average age was 63. So that means more than half the women were quite a number of years out from menopause. But among these women, randomization to estrogen plus progesterone oral therapy was associated with excess risk of cardiovascular disease. Most of the excess risk was all seen in the older women. There didn't seem to be an excess risk in the younger women. And that has been a lot of interest in the timing hypothesis. And unfortunately, we don't have a lot of good data there. There was some studies like the KEEPS and ELITE trial that didn't show a benefit on carotid IMT or coronary calcium when hormone therapy was given in the perimenopausal period, but at least appeared safe. There was no excess risk. But then there was this open label randomized clinical trial from Denmark that did enroll women 45 to 58 who were recently postmenopausal or perimenopausal, and did show that hormone therapy did reduce the risk of cardiovascular events, particularly for women under the age of 50. So this gives some more credence to the timing hypothesis. However, at this time, it's still not recommended that we're using hormone therapy for the purposes of cardiovascular disease prevention. But given the safety data, we are still using hormone therapy for women under the age of 60 or within 10 years of menopause who have symptomatic menopausal hot flashes or night sweats. And I should mention that frequent vasomotor symptoms, even in of themselves, are associated with cardiovascular risk. So women who have more frequent and have persistent vasomotor symptoms, that's associated with risk. We also can use hormone therapy in women that have an early menopause to use up to the age that they would get to the natural menopause. But generally, we're not using menopausal hormone therapy if a woman is more than 10 years out from menopause or over the age of 65, and really to avoid oral estrogens in women with a history of cardiovascular disease, blood clots, high triglycerides, gallbladder disease, prior breast or endometrial cancer. It does seem that transdermal estrogen at least have been safe in patients with a history of stroke. So really the route matters also as much as timing. But really recommending all women have a cardiovascular risk assessment prior to using menopausal hormone therapy. And one thing I use a lot in my clinical practice is getting those coronary calcium scores to see if a woman has atherosclerosis or not. So I was part of the 2019 American College of Cardiology, American Heart Association primary prevention guidelines. And I was really pleased that they recommended, after we do the 10-year risk score, we know that's imperfect, that they consider these risk enhancing factors that are not in the risk calculator, but also increase risk that may also favor treatment with statins. And I was really pleased that they now include these female specific factors of premature menopause and adverse pregnancy outcomes like preeclampsia as a risk enhancer. And they also mentioned inflammatory conditions like rheumatoid arthritis and lupus that are more prevalent in women. And there's a number of other ones related to lipid biomarkers and ethnicity and kidney disease. But the guidelines acknowledge that even after you estimate 10-year risk, of which the US guidelines has now moved to this pooled cohort equation, even after you estimate risk, and even after you consider those risk enhancing factors I showed you on the previous slide, there's sometimes still is uncertainty about a woman's risk or patient indecision about the net benefit of statins or patient reluctance to starting a statin. I mean, do we put all women with a history of preeclampsia on a statin? I mean, maybe so, but there can be sometimes some uncertainty. So the guidelines say when there is clinical uncertainty, you can get a coronary calcium score, which was a 2A indication, to refine risk a little better and help guide shared decision-making. So a coronary calcium score is done by non-contrast cardiac CT. It's gated to the EKG, so it's very low radiation, about 1 millisievert, which is the same as a mammogram, or it's also the same as the background radiation in the US over 1 year. So it's not the same as a full lung CT. No, as atherosclerosis is developing the arteries, a certain percentage of it can become calcified, and calcium can show up bright white on x-rays like bone. And so it's a very good marker that there is atherosclerosis there. And it's in multiple cohorts. I'm going to show you one, but it's really emerged as a superior prognostic marker of risk. It predicts risk better than age. It predicts risk better than the risk factors. So, because it's likely the reason why it's such a good marker of risk is that it's really measuring the disease itself. It's saying, hey, there's atherosclerosis here. So it's really integrating a lifetime of risk exposure from genetics and traditional and novel risk factors. And it can be used if it's present, meaning that there's atherosclerosis there, you can upgrade risk and treat with a statin. Or if the score is 0, potentially it puts someone into a lower risk category. You can defer statin therapy if that is the patient's desire. So since this is a women's talk, what are the sex differences in this? So at a given age, women are less likely to have prevalent coronary artery calcium than men. But when present, it's still very predictive in women. So this is data from the multi-ethnic study of atherosclerosis that I was part of. And this looks at cumulative risk. This is risk of a hard atherosclerotic cardiovascular event over 10 years. And this dotted line marks the 7.5% 10-year threshold. And this is a threshold that's been accepted in our guidelines. It's a high enough risk that might warrant a statin therapy for prevention. So, what was shown is that a 0 calcium score is associated with a very low event rate over 10 years. And this is light gray line. So a 0 calcium score is not a 0 risk. I mean, there's still some events. It wasn't 0 events, but it was well below the 7.5% 10-year threshold. And it's, in a range that's low enough that clinicians and the patients may feel comfortable or wish to desire to hold off on statin therapy and focus on lifestyle. On the other hand, any non-zero score crosses that 7.5 threshold in 10 years in a graded fashion, with the higher the score being associated with a higher risk. So our guidelines do recommend really, anybody with a non-zero score to take a statin, but particularly higher scores above 100. Now, while women have a lower prevalence of coronary calcium than men, when it's present, it actually confers a greater risk in women. And this is data from the Coronary Calcium Consortium looking at cardiovascular mortality. So when the score is 0, this is a very favorable prognostic marker in both men and women. So this is cardiovascular mortality over 20 years of follow-up here. I guess it gets truncated at like 15. And this, just so you can see the scale, this is 1%. So a score of 0 over greater than 15 years is associated with a very low mortality rate. But on the other hand, when the score is not 0, when it's prevalent, this is associated with risk in both sexes, but it's associated with a 26% greater relative risk in women than in men. And we see this across scores when the score is above 100 or above 300, or if there's 2 arteries or 3 or more arteries involved, that when it's present, it's a greater risk in women than in men. The same data set that looked at this among patients with diabetes. And again, you can look at these event rates. These are mortality event rates. And so for both men and women, the mortality goes up as the score goes up, but it's a much greater increased risk in women, greater rates in women for a given score. And then when you adjust for risk factors, again, the presence of coronary calcium as the score goes up predicts mortality and CVD mortality in both men and women, but it's a greater relative risk in women for both all-cause and cardiovascular mortality. And this was a significant interaction by sex. Now, we use coronary calcium in asymptomatic individuals. This is for risk assessment, like we're trying to decide about aspirin and statins. But what about symptomatic women? Well, women actually, on average, have more angina than men. Angina is a marker of a ischemic heart disease. And what I mean by ischemic heart disease, it means that the heart is unable to provide sufficient, the coronary arteries are unable to provide sufficient blood flow to meet the metabolic demands of the working heart. And you can see the prevalence of angina is higher in women. But in the setting of angina, women are more likely to have non-obstructive coronary disease compared to men. And we see this at all age groups. So there are many reasons why, if you don't have an obstruction, how are you still having ischemia? Well, there's been a lot of interest about dysfunction in the heart's smallest arteries. So you hear the large arteries, which is the kind we see on an angiogram when we say there's no major obstruction. But the arteries branch into smaller and smaller and smaller arteries. And it's these microvascular circulation that can get dysfunctional, particularly when there's risk factors like smoking and diabetes. And it can lead to endothelial dysfunction, impaired vasodilation in setting of exercise. And then you can also have microvasoconstriction. And this is how you can get ischemic, even without an obstruction in the large artery. But it's important to note that even if there's no obstruction, these arteries are not normal, and women benefit just as much from risk factor screening and treatment. In the WISE study, the Women's Ischemic Syndrome Evaluation, here's an angiogram, and it looks pretty normal. There's no obstructive disease. But when they did something called intravascular ultrasound and put an ultrasound down in the artery, they saw that 80% of these women did have plaque. So these arteries were not normal. They did have plaque, which is why it's, and plaque was associated with symptoms and risk factors. And so this is why it's important that we identify these women and we put them on appropriate therapies, including aspirin and statins. And we did women for years a disservice where they said, oh, your stress test was a false positive because you don't have obstructive disease. Well, WISE showed us that women, even who have angina, ischemia, with non-obstructive disease, this is still associated with an increased risk, a 5-year risk of major adverse cardiovascular events. So these are women with ischemic symptoms, mild non-obstructive disease. Here's the pink. no obstructive disease is here in the yellow. And, compared to women who are completely asymptomatic, having this non-obstructive disease, it was associated with the increased event rate. So we need to pay attention to that and not falsely reassure women, get them on the appropriate therapy, both to help with symptoms. You can put them on anti-anginal therapy, but also really to prevent vascular events by putting them on disease modifying agents like statins. So here is a review article that, again, Dr. Michos led with me. We just talked about sex differences in plaque. So men tend to have larger coronary arteries, a bigger lipid core. They tend to have more calcification, a thicker cap. Women tend to have smaller arteries, lower plaque volume, but there's some thought that because their arteries are smaller, that they may have more relative burden of plaque related to the size of the arteries. They have less calcification and more non-obstructive disease. So another area I've been really interested in is sex differences in patient-reported outcomes, patients' experience with the healthcare system. Because if we want to make things better, and provide care, our women patients have to have a good experience in our healthcare system, and our data suggests that they are not as having a good experience as men. So we looked at a U.S. data set, and we focused on women and men who have atherosclerotic cardiovascular disease, because this is high risk for recurrent events, and we have established therapies. And this study represented 11 million in the US who have cardiovascular disease already. And even after we adjusted for age and race and socioeconomic status and education, even when we adjusted for other comorbidities and cardiovascular risk factors, we found that compared to men, women were 25% more likely to report that they had poor communication with their healthcare provider. And they were 23% more likely than men to report that their doctors never or only sometimes listened to them. And they were 20% more likely to say that the doctors didn't show them respect or spend enough time with them. And they were more likely to have poor patient satisfaction. So initially, when we submitted this paper, we got back from the reviewers, I think it was reviewer 2. Oh, well, this is self-reported data. Maybe women just whine more. Maybe they just expect more from their healthcare system. Maybe, that they're more likely to complain. So this is all just subjective. So we went back to look at objective data, because these were all women with vascular disease where aspirin and statins would be a class 1 indication. And we found that women were 45% less likely to be treated with statins, and they were 35% less likely to be on aspirins, and they were 28% more likely to visit the ED. In other words, women were being treated suboptimally, and they felt that way too. And so the last thing I wanted to touch on, you heard about, I'm really interested in how we can improve enrollment of women into clinical trials, because all of our guidelines is all based on clinical trials. And, we're doing trials, we may not know, if a drug is going to work or not work, but there's a lot of advantages with participating in trials. Women, people who participate in trials have more access to the healthcare system, more access to the gold standard of care. And it's really important way that we improve innovation in women's health, and physicians, clinicians play an important role in referring and recruiting women to clinical trials. So why do we need women in trials? Well, this is an older study. This is from the year 2000, but they looked at drugs that were already out on the market. So these were drugs already widely used in clinical practice, but had to be pulled off the market because of safety risks. And in 80% of these drugs having to be pulled off the market, some of these are fen and things you might have heard about, they proposed a greater risk in women than in men. So if you have more enrollment of women in these trials, you're going to have better safety data in women and more safer drugs. Women are not smaller men. There's differences in how drugs, interact based on body size, body composition, sex hormones. And so you can't assume just because a drug works in a man, it's going to work in a woman. One of my heroes in this work has been Dr. Bernadine Healy, who was the first female cardiology on faculty at Johns Hopkins. She was the director of our CCU, first woman full professor in cardiology at Hopkins. After she left Hopkins, she went to direct the NIH and was the first female director of the NIH. And then she directed the Red Cross. Unfortunately, she died too young of brain cancer. But when she was at the NIH, and she was the one at the NIH who really pushed forward the Women's Health Initiative study, WHI, that I showed you with the sex hormones, and there were several other WHI studies. And nobody really wanted to fund this because it was expensive and large, and why do we need to fund a big study in women? And she really pushed them forward that they had to do this. And she also wrote this seminal editorial in the New England Journal of Medicine that coined a whole syndrome called Yentl syndrome. So maybe I'll write editorials that end up coining a whole syndrome. But this was a story of Yentl, who it was a woman that had to dress up like a man in order to go to school and be treated equally. And Dr. Bernardine made the point that cardiovascular disease is a disease of women, and it shouldn't have to dress up and present exactly like obstructive disease in men to be paid attention to. And she said, until gender balance is achieved in trials, research is important, that we addressing gender-specific differences in cardiovascular disease, that Yentl syndrome will continue to live on. So as mentioned, the guidelines are largely based, at least in cardiology, all on randomized clinical trials. And it's not like there's not recommendations in place. I mean, for decades, the NIH has recommended inclusion of women in trials, and the FDA has recommended reporting sex in clinical trials. But we took a look at some of these trials and try to see, well, how good are our trials really doing at this? And so we examined trials of lipid-lowering therapy and cardiometabolic drugs to examine the pattern of women representation in trials. Now, for some of these diseases, like acute coronary syndrome, this is more prevalent in men. So we benchmarked it to the participation in the trial relevant to the disease burden in the population. And so a participation to prevalence ratio of 1 would mean that they're adequately represented related to their disease burden in the population. And starting with lipid-lowering trials over 3 decades, we showed that women were only 29% included, although there was a slight uptick over the years, that women were still underrepresented. And when we can benchmark it to their disease prevalence, particularly for heart failure and coronary disease, women were underrepresented relative to their disease prevalence in the population. And then we did this for cardiometabolic drugs. In this trial, we focused on 10 years of data about trials that were submitted to the FDA to get a new molecular entity approved, to get a new cardiometabolic drug approved. So these were diabetes drugs and cardiovascular drugs. So these are pivotal trials. This is how you get the label indication for the drug. And we really showed over this decade, no uptake of women in the trials, who only made up 36% of the participants. And again, similar to lipid trials, women were underrepresented, particularly in heart failure and coronary disease. Interestingly, they were overrepresented in pulmonary hypertension. And then in this editorial that I wrote with one of my colleagues, Dr. Khan, who's a cardiology fellow, we looked at the literature of other trials that have done this, other studies have done this, and really shown across disease entities, stroke, acute coronary syndrome, heart failure, arrhythmia, hypertension, lipid lowering, that women are underrepresented relative to their disease. So the pink bars are the number of women in the trials, and the purple bars is the proportion of disease in the population. And you can see that there's less women in the trials relative to their disease burden. So why is it, how can we do better in this? And one thing I've been passionate about is getting more women into science, getting more women into medicine, getting more women into cardiology, because there's actually a link between the gender of the author and whether the study reported a gender and sex specific analysis. So in this paper, which isn't specific to medicine, it was 1.5 million medical papers across all kinds of different diseases and research in countries. But it was much more likely that the study would report a gender and sex specific analysis if there was more total women authors on the study, or if the first author was a woman or the last author was a woman. But unfortunately, in cardiology, we're doing really bad at this. Looking at this paper published last year, they looked at cardiovascular trials published in the last 4 years in leading journals. So again, these are pivotal trials in my field in cardiology. But only 10% of clinical trial leadership committees were women. And half of these clinical trials had no women on their leadership steering committees, and less than 10% had a woman as the first author or the last author. So does it matter if the authors or trial investigators are women? Well, actually, studies suggest that it does seem to matter. This was heart failure trials led by paper with Dr. Jessup, showed us the proportion of women authors, meaning the trial leadership went up. There was more women patients in the trials. And we showed this too in an analysis that I did looking at Afib trials over 30 years, that we showed that there was only 35% of women patients in these trials. On average, there was only 1 woman author per these publications, but there was a correlation. For every 1% increase in women author panel, there was a 19% increase in women enrollment in trials. And we also examined, guidelines. I know there's a lot of trying to make guidelines more inclusive, and there has been an uptick of women authors on cardiology guidelines from the ACC/AHA, but it's still been suboptimal, and particularly in interventional cardiology or electrophysiology, likely because there's very few women in these fields, that they have very few women on these guidelines. So the summary of this part of it is that women continue to be inadequately represented in cardiovascular clinical trials compared to their disease burden. And this really impairs our generalization of, we take these trial results and whether they apply to the women patients we see in our practice every single day. And so we need practical steps to improve recruitment. And, one area I think is really important is efforts to recruit and retain women trial investigators, I think can help lessen the disparity in both areas. And so I've led a number of position statements about how we can do better about getting more women into trials. I really think that we need to get more women patients involved up front in the design of the trial to understand barriers of why the trial may not be attractive for women to enroll in them. And we also need to diversify study team investigators. And for women patients that are approached and decline, trying to understand why, because maybe there's something we can fix in terms of, feasibility of follow-up. We want to make sure our inclusion criteria are not too restrictive, that, we can't exclude all women of childbearing age just because they might theoretically get pregnant. I mean, we do a lot of women disservice by ignoring women of childbearing age in trials, and we have very little data of women in pregnancy. And education, women tend to overestimate risk and underestimate benefits. And so it's really important that good communication, dispel misconceptions, emphasize there's a lot of benefits of just being in a trial and having more flexible follow-up. And this is something we did do better with during COVID when we couldn't do the in-person visits, but it can be really hard to come in for in-person visits. So doing follow-up when possible on weekends or by phone or through one's primary care doctor, avoiding hidden costs. So usually the drug or the device is covered by the trial, but there can be other costs related to transportation to the study visit or time off work, and engaging patients into the knowledge translation and dissemination of results, and always collecting sex-specific endpoints. And then in this review I led in Nature, in addition to those trial teams and trial designs, we also gave recommendations of what funding agencies can do and institutions can do, and journals themselves, who publish these studies, I think should request justification for homogeneous authors and homogeneous trial participants. So my last slide, because I want to have time for your questions, is cardiovascular disease is the major cause of death in women worldwide. Women and men share many risk factors in common, but several are unique to women. Reproductive history is very important to ask to identify for early prevention and treatment of cardiovascular disease, that atherosclerotic plaque is prevalent and it predicts risk even when not obstructive, and you can have coronary dysfunction even when there's not obstructive disease, that women are underrepresented in clinical trials, results are often not reported by sex. Listen to women when women are telling you something is wrong, to listen to them. Women often get their ischemic symptoms dismissed as just being anxious, and missed opportunities. We want to improve. There's a lot of things we can do to improve representation of women in trials and in trial leadership. And just a plug for the journal, as you heard, I'm a co-editor in chief of American Journal of Preventive Cardiology for the American Society of Preventive Cardiology. So any of you doing work in the field of prevention, I'm very interested in maternal health and cardiobstetrics as it relates to improving cardiovascular health. So submit to our journal. We're open access and we're indexed in PubMed. And I just want to thank my mentees. I couldn't list them all, but they really are the force behind all this work. And nothing gets me more excited as an investigator to work with these bright stars. And I just want to thank all of them for all of their efforts to this work. And I want to happy to take your questions.
Erin, that was terrific. We'll give folks a chance to either raise your hand or type a comment in the chat. I'm going to throw out a first question while folks are gathering their questions. So you showed some really striking data about the lack of awareness of, the risk among women. What are thoughts of what we ought to be doing in public health to address that? And is it education of providers mostly, or is it education of women, or is it a combination?
Well, I think it's both, but I think we really need to engage our community. So one of my favorite studies was the barbershop study of hypertension in Black men. I know this was men and not women, but I think we should do the same thing with the salon hairdressers. But training barbershop who are not medical people, but training them how to measure a blood pressure and give that information back, and working with pharmacists, they were able to improve blood pressure outcomes in these men. And I think some interesting work by Little Princess Brewer, who did her training here at Hopkins and now is a cardiologist at Mayo, has been working with faith-based organizations, Black churches, predominantly Black churches. So I think we need all hands on deck. And I think that, there can be some, rightfully so, because of all the history of mistrust with the medical community. And I think that's why we need community leaders to be advocate. We saw this with COVID vaccinations, and I think this with cardiovascular disease. So we need to partner with the community leaders. We need all hands on deck. So I think that's an important message, that just us sitting here in our clinics and, we're not clearly disseminating the message in an effective way. And I think that providers do need to continually have some reminders that cardiovascular disease hasn't been fixed. Even though a lot of our thoughts now have been on infectious problems with COVID, cardiovascular disease prevention can't wait. And we need to make sure that we're still treating cardiovascular risk factors. So I'm hoping to engage all of you. You are all public health leaders and getting the message out there. And I'd love to hear your thoughts about how we can do better. I was really sad when I saw the study. I'm like, how is it going down? Like, we've been speaking about this for, decades.
Yeah, I think what's so interesting too, as you were sort of alluding to, is, women come in for a variety of services that men don't necessarily come in for it. So it seems like a lot of missed opportunities to engage in the communities where women are at, and hearing from them who they want to hear messages from. So thanks for your thoughtful comments. I see a comment posted in the chat from Gabrielle Foster, and she says, would you recommend earlier intervention testing for young minority women with chronic diseases?
Yeah, so, of course, it depends what chronic diseases, but certainly diseases such as chronic kidney disease, type 1 and type 2 diabetes, and type 2 diabetes is occurring in younger ages, including in adolescence. Lupus, which more affects Black women more so than other populations, and inflammatory diseases. So there can be earlier onset, polycystic ovarian syndrome. So I think raising awareness that just because a woman is young does not mean that she's not at risk for cardiovascular disease. In fact, diabetes and smoking completely negates this female advantage of the later in life. And we know that women with these inflammatory diseases like lupus, they're at much greater risk of cardiovascular disease. So we do need to screen risk factors in everybody. And so we don't miss things also like FH, familial hypercholesterolemia. But I think we do need to identify and start treatment earlier, and not treat these women just under some perception that somehow their young age might protect them. I mean, one of the biggest risk factors for being inappropriately sent home from the emergency room, who were later diagnosed to realize to be having an acute coronary syndrome, but were initially not diagnosed, was being a woman under the age of 55, and particularly also with being a minority woman, more likely to have their symptoms dismissed. In another study from Virgo looking at MIs in young adults, again, for individuals who presented with MI who previously had symptoms, women were far more likely to be told that their symptoms related to a non-coronary cause like anxiety, when it later turned out to be coronary disease. So I would recommend risk factors. The question is other kind of screening. Sometimes coronary calcium hasn't, atherosclerosis hasn't calcified yet at younger ages. So a coronary calcium score sometimes is less helpful under the age of 40. This is where not IMT, but carotid plaque may be helpful as a marker of atherosclerosis, but really it's just making sure that risk factors are treated.
Great, thanks. I see some comments coming into the chat. Not everyone may have access to it. So Xiaobin Wang comment, thank you for your awesome talk, and then said, wonder about your thoughts on the link of maternal mental health during pregnancy and postpartum and their long-term cardiovascular disease risk.
Oh, yeah, this is so important. I was also on a AHA statement published this year about the mind-heart-body connection. So there's lots of risk factors about impact of mental health on cardiovascular risk. And, some of it is, what is the chicken versus the egg, what came first? And there's probably both indirect and direct causes. So, indirect causes. So people who have a worse mental health, under more stress, more anxiety, more depression, they're more likely maybe to have poor coping mechanisms. They're more likely to smoke or drink or not exercise or not follow healthy nutrition or not go for routine follow-up if they don't feel like they have, optimism or a sense of purpose for the future. So those are indirect mechanisms, but it's also thought that there's direct biological mechanisms. So when people are under chronic stress, this leads to this revved up sympathetic nervous system that may trigger this inflammatory cascade where you have higher levels of inflammatory markers, more cortisol, you're constantly revved up, and that may directly, with increased heart rate, increased blood pressure, directly lead to cardiovascular risk from a causal mechanism. So it's really important that we address mental health, that we screen for people that are having duress from their mental health, and make sure they have the resources and support and coping mechanisms, that this is really important and neglected. And again, one of the things, if you don't ask, you'll never find it. So.
Great. I'm going to turn it over to Allison Gemmel, who posted a comment in the chat. Allison, do you want to come off mute?
Yeah, sure. So thank you for this talk. I learned a lot. So one of the things in population-based surveys is that we're not asking men about their reproductive history. So that includes like in the NHANES, for example, and then in studies like Women's Health Initiative, obviously, and Nurses Health Studies, the other one, men aren't included. But then it's interesting when studies look at both men and women, they kind of find similar relationships depending on the exposure, which points to more social versus biological. So, I mean, obviously there's a lot to tease out, but it seems like we need to advocate for, asking men about their reproductive histories as well. I wonder if you had any thought about that.
So I completely agree. As you mentioned, there is some interesting data that parity is a risk factor in Grand-Monte parity is a risk factor in men, who of course are not the ones being pregnant, but that it may be related to socioeconomic challenges and related to an environment and diet, and ability to have physical activity and just have the time when you are caring for multiple children. So a lot of studies don't compare women and men directly, and they should, but also men have unique risk factors too. So erectile dysfunction is a red flag of risk for men. So the penile arteries are smaller than the coronary arteries. So there can be the onset, and I'm mostly referring to vascular ED, of course, but there can be the onset of ED can herald the onset of coronary disease by a number of years. And so if you ask men about ED, because often they don't bring it up because of embarrassment or whatever. And so, but if it's present, this is a sign of endothelial dysfunction, atherosclerosis, and this would be a missed opportunity to treat men on appropriate risk reducing agents. So we need to ask about that. And there's also been interesting, not enough data, but about potential risk about testosterone therapy in men. And safety related to that. There's an ongoing trial right now, but there's an FDA warning right now not to use testosterone therapy unless there is a documented testosterone deficiency and symptoms of hypogonadism because of the increased vascular risk that's been shown. So we need to ask men not only for these social risk factors that may be capturing, but also biological factors as well. So we just need to ask these questions.
Great. And I think we have one more time for one more question. I'm going to read the last one from the chat from Tiago Costa, who asked if the risk of increased cardiovascular disease in postmenopausal women with higher testosterone levels is associated with higher blood pressure.
Yes, so the higher testosterone levels in women are associated with increased blood pressure. In our analysis, we adjusted for blood pressure. We still saw an independent risk. But this brings up the issue, which I didn't get to talk about issue in transgender women and transgender men, where, again, we don't have trials in this area, but there's some observational data from the Netherlands that trans men who were female sex at birth, male gender identity receiving testosterone therapy have increased risk of myocardial infarction compared to cis women. And they also have more elevated blood pressure and cardiometabolic risk factors. And so this is not to say that we would not use gender affirming hormone therapy, because gender identity is so important, although these are much higher doses often than endogenous levels. And so it's really important that these individuals have a comprehensive cardiovascular risk screening and that we control all their risk factors, including their blood pressure and their lipids and smoking cessation, to kind of help mitigate any risks that may be related to the hormone therapy itself.
Great. I'm seeing lots more questions in the chat, but I'm also aware we're just about out of time. So many of the students in our department are taking life course this term, where we're thinking a lot about how factors across different levels impact health across generations and over different stages of the life course. So a lot of what you shared is really great food for thought for all of us. So Erin, I just really want to thank you for joining us today. Everyone, please join me in a virtual round of applause. It's a terrific start off to the seminar series, and we look forward to interacting and collaborating with you, and to wish everyone a great rest of the day. So thanks so much for joining us.
Thank you.
Take care, everybody.